Hi, this is Elliot Fishman. Welcome to part 5 of our talk on large adrenal masses. Now, I can't remember if I've ever done a 5-part. We often do 4 parts, but 5 parts, wow. And that's because I wanted to show you a whole lot of cases, because really with adrenal, most people do not see so many cases, and so their experience is limited. I thought that if I can show you a lot of adrenal cortical carcinomas, lymphomas, adenomas, angiomyolipomas, all of the different things, the rare things, ganglion neuromas, that may help you in your practice. So I hope you enjoyed it, but let's keep going. When you talk about bilateral adrenal masses, a number of things can be bilateral, right? I just showed you lymphoma. Mets, I showed you that as well. We talk about adenomas. We talk about bilateral maculonodular adrenal hyperplasia, which we did not discuss in this talk. Infection can be bilateral, be it TB or blastomycosis. The one that's most common bilateral, when you look at the percentages of bilateral masses beyond adenomas, is going to be pheochromocytomas, okay? About 10% of pheos are bilateral, but they make up a high percent of the bilateral adrenal masses, so something to think about. Pheos, incidence, age 40 to 50. The rule of 10s, multicentric. 10% are extra-adrenal, 90% are near the organ of Zuckerkandl, and about 10% are malignant. So we always remember the rule of 10 with pheochromocytomas. Classically, pheochromocytomas are very vascular. When I showed you metastatic renal cell carcinoma before, I made the point, if you have a vascular adrenal mass and its patient does not have renal cell, they have pheochromocytoma. Or they have pheochromocytoma till proven otherwise that they have a renal cell carcinoma. The thing about pheos, they don't always need to be vascular. They can also be large or they can be small. Now, I have to admit in this case, it's very vascular, but if you told me this was adrenal cortical carcinoma, I would say, well, it's pretty vascular, but it could be. And of course, you get the metanephrines and you'll be able to make a very specific diagnosis. Here was a patient presented with a vascular lung nodule, right lower lung. Look at this lesion in the adrenal. Look at the vascularity around the edge. There's a description of a ring of fire. I've seen this same appearance on PET scan, where there's a giant rim of enhancement because there's central necrosis. Although we typically think about pheos as being very vascular throughout the gland, they are one of the tumors with central necrosis, metastasis, primary ACC, but prominent vascularity around the edge and central necrosis. You can see the neovascularity very nicely shown here. A really great example of a pheochromocytoma. Again, it would be hard for me to say without any lab work or history that the patient did not have a primary ACC. So that would still be in the differential diagnosis. You can see as you go to venous phase imaging, the thickened rim, the central necrosis, really good for a pheochromocytoma. So when you think of adrenal masses with cystic or necrotic change, obviously simple cysts, lymphangiomas would be put up in there. Then metastasis, particularly melanoma, pheochromocytoma with that central necrosis with peripheral rim enhancement. And of course, adrenal cortical carcinoma can also have areas of necrosis. Usually it's intermixed with areas of increased vascularity. So a pearl for pheos: perform biochemical evaluation for adrenal mass under 4 centimeters with cystic or necrotic change and hyperenhancement, even if the absolute washout is 60%. Now remember, one of the things I've told you many times, pheos do wash out. When you're doing an adrenal lesion and the 60-second images, it goes above 120. Some people say 110, but surely above 120. I don't care how fast it washes out, it's a pheo till proven otherwise. So pheos will wash out very quickly, so you want to be very careful you don't make a mistake in diagnosis. And here's the case from a few moments ago. Very nice peripheral vascularity, very nice central necrosis. In this article, we wrote about how pheos can look so variable. As pheos enlarge, the masses tend to undergo ischemia and necrosis, which is why you have central degeneration and fibrosis. Predominantly cystic pheos are rare, but it's the same pathology: hemorrhage, necrosis. The ring sign, defined as a hyper-enhancing rim, is characteristic of a cystic pheochromocytoma, seen in 40% of cases in one series. I don't think it's that percent, but we saw a beautiful case where there was an MR recently, a non-contrast CT. We're waiting for pathology, but I'm sure it's going to be a pheochromocytoma. So again, very, very important ring of fire. When you think about Pheos, and in one of the other talks I did a lot more about Pheos, we talk about, and you could do a whole talk on pheochromocytomas, quite frankly, presentation, hypertension, palpitations, headache. But 10% are still asymptomatic. Again, another rule of 10. Pheos are associated with syndromes. MEA2, von Hippel-Lindau, neurofibromatosis, Sturge-Weber, and tuberous sclerosis. Well, up to 95% of Pheos are benign, 10% to 15% can be malignant. And again, diagnosis based on elevated urinary and plasma, metanephrine levels, and catecholamines, in addition to imaging features. Again, sometimes you'll have the Pheo and you don't see an adrenal lesion. We'll talk about that in the Pheo talks. But then you look for extra-adrenal Pheos, be it at the organ of Zuckerkandl or maybe even in the bladder. When we were doing the article on adrenal masses with cinematic rendering, we talked about the vascularity and the tissue characterization of these vascular lesions, which can be very helpful for surgical planning as well. Now, the last thing I'll mention is uncommon primary adrenal malignancies. These are rare, very, very rare. Pleomorphic sarcoma, primary adrenal leiomyosarcomas, adrenal cortical carcinosarcomas, primary epitheliosarcomas. We see one of these every 5 to 10 years. I just have a couple sets of images. Primary adrenal pleomorphic spindle cell sarcoma is rare. Commonly occurs in the extremities, but can occur in the adrenal glands. Here is a large mass, non-contrast. Again, hard to tell here if this wasn't renal or adrenal, but we're going to say it's renal, and it looks like it's involving the kidney. So I would think maybe this could be lymphoma. Maybe it's a big ACC. I'm sure it's a malignancy. Remember that one case I showed you of vascularity? There is some vascularity. We had a funny adenoma before, but the way it infiltrates the kidney, I'm definitely going with a malignancy. Again, ACC is probably my best bet. I would throw in lymphoma. But at the end of the day, this was resected. Here's the neovascularity. Here is the washout appearance. Central necrosis. Again, ACC still stands out as my best call. Here's a cinematic rendering. So we did everything right in this case. We evaluated it multiple different ways, multiple different images, showed the neovascularity. We knew it was malignant. The patient was operated on. They did adrenal removal. They did a nephrectomy, and that was a sarcoma. Another patient, large mass. Is it the kidney or the adrenal? There's infiltration. There's nodes again. You would think about if it was kidney, it would be lymphoma. Lymphoma with adrenal. Could this be adrenal because of the shape, but then also the extensive node? So then I'm thinking about lymphoma of the adrenal, infiltration around the vessels, and the vessels, you still can see the left renal artery. So I got to be thinking my best bet here maybe is going to be lymphoma. You can see the infiltration here. And so I'm still thinking it's going to be lymphoma. Then if you look hard, you can see this infiltration and extension to the left kidney, which is poorly functioning. Again, that's not the appearance of an ACC. It's not the appearance of metastasis. It's more the appearance of lymphoma. And of course, this was an epithelioid angiosarcoma of the left adrenal gland. I've seen a total of 1, so I can say they all look the same. So if I have a big adrenal mass that involves the kidney, that's what I'm saying. Well, I still am going to say lymphoma. But a really unusual case. Again, making the point there are uncommon adrenal sarcomas. You're going to treat them like ACC. They're going to be resected and only on pathology. Or this case, I look at this one, I say punctate calcifications. Maybe I'm dealing with a myelolipoma. They have punctate calcifications. There's some abnormal enhancement here. Myelolipomas can have funny enhancement. So what exactly am I dealing with here? Vascularity, calcifications, big mass, it's solid. Think about myelolipoma. It would be very atypical. And if it was a myelolipoma, I'd have to resect it anyway. It's over 5 cm. It's more like 8, sharply marginated. This was resected. And again, if you had to ask me, I probably would have favored a benign lesion, but I couldn't be certain, quite frankly. And this was another epithelioid angiosarcoma. Vascularity, but I showed you vascularity like that with hemangioma. I've showed you that with adenoma. I've showed you that with myelolipoma. So it's not the worst vascularity I've ever seen. And calcifications to me, particularly when they're punctate, I got to be thinking about myelolipoma. But it just shows you that adrenal lesions can be very difficult. So we looked at a number of different things, and we've gone through all of them, and I've showed you many examples. If you ask me the question, what's the future of adrenal imaging? I think it's learning the rules, a closer combination of the metabolic and the endocrine lab values with the imaging will make our job a bit easier. I think one of the things to also think about, again, is this idea about thinking, clinical context, hormonal assessment, imaging phenotype, putting everything together. And again, the importance of a multidisciplinary team cannot be overemphasized. Now, in looking at the future, everything is AI, everything is deep learning. Here's an article looking at adrenal mets from benign lesions with deep learning, and they had some reasonable results. It was a reasonable amount of patients, but typically that's not going to be all that difficult. I think it'll be interesting to see how good we are in using AI, particularly if you have lab values. It should be very easy to be able to be very specific in terms of diagnosis. And so this one, the deep learning model based on PCP-CT images, performed acceptable in differentiating mets from benign lesions and may assist radiologists in accurate tumor staging for patients with a history of extraadrenal malignancy. So perhaps it will be helpful. And as we know, with all parts of radiology, from lung to PE to mets in the lung to pancreas to liver to spleen to adrenal and kidney, AI is where everything is going to change. We'll see how successful we are, but I think it provides great opportunity. So again, in this article, they showed the performance of AI was just as good as radiologists with moderate years of experience, whatever moderate means. But again, it's a challenge, and AI is in the early stages. If it was a baseball game, we're in the first inning. So by the time we reach the end of the game, I do believe AI will be very strong and be competitive and will be helpful to us in terms of looking at all of the data and coming up with specific lesions. So again, we got the differential, we know specific findings, and I wish you the best of luck on your next difficult case. And with that, I appreciate everyone paying attention, and I hope you have a great day. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.